So I'm a pain psychologist. So I've run inpatient, outpatient pain programs, and currently I do 2 days a week at the anesthesia pain clinic on the 18th Street, and then a day here, and then 2 days of research. And most of my research has been around kind of pain care and vulnerable populations. We have some work in the HIV population, patients that I'm on a grant that's looking at patients who are end-stage renal kidney disease that are on dialysis 3 days a week. We have this large grant trying to use a cognitive behavioral therapy to kind of improve their pain and quality of life. So it's kind of vulnerable populations. Thing with pain patients, and I've, as a precursor to this is kind of a touchy subject on suicide. So if someone feels that that's uncomfortable, you should probably not be here. And interesting, I was giving a talk at the American Society of Addiction Medicine, like 300 people were there. And I said, how many people know someone who has thought about suicide? Almost every hand came up. How many people have thought about someone who's tried suicide? Almost came up. So it's not an inconsequential problem. And I think the pain population in particular, and patients who have pain and substance use disorders, are at incredible risk of death by suicide. And I think the obsession with the opioid epidemic has kind of really buried this, that, oh my God, opiates are the devil's dandruff, and that's what we should worry about. And it really kind of overshadowed these kind of very vulnerable populations. So what I'm going to do is kind of go through a lot of things, and we'll take time just to ask questions. This is what we're going to accomplish right there, all in an hour. So if you look at global statistics, this is a 2019 article by the World Health Organization. So every year, about 700,000 people die by suicide. And you have to understand, a lot of people think of death by suicide. Very, very small percentage actually die by suicide, but they have this ideation all the time. So since I've been talking, how many people have died worldwide? Every 40 seconds, someone dies by suicide. For every suicide, there are many more people who attempt suicide. Prior suicide attempt is probably the number one predictor. You can be the best mental health provider, psychiatrist, psychologist, and it's really hard to predict who's going to die by suicide. Right? 77% of global suicides occurred in low and middle income. Why is that? Why low income? We all know the answer to this, right?
They have less access, or harder access to mental health care.
Right. And there's the social determinants of health, right, that we talk about a lot. And number one risk factor for developing a substance use disorder. Anyone know? ACE. And that's adverse childhood events. So people who are living in low income and there's violent neighborhoods, they're set up for a lot of different problems, right? A lot of the patients who end up with end-stage kidney disease are African American. Why is that? Because it's low income, food shortage, forced flues. If you drive up Broad Street, like up by Temple, what's on every corner? Popeye chicken, there's McDonald's, this and that. You get into the suburbs, it's Panera Bread and Salad Works. So a lot of these things are they're set up to really have a very difficult time. So experiencing conflict, disaster, violence, abuse, loss, or sense of isolation are strongly associated with suicidal ideation, and it's highest among the most vulnerable populations. Do we do anything about that? Not much. So even if you look at the field of treating people with opioid use disorders like Kensington, so they medicalize it so everyone gets buprenorphine. It's in the drinking water. But 2/3 of the problem is poverty and exposure to violence that we don't really address. This really surprised me. Of the 1.5 million violent deaths per year, 54% were suicide. I found that actually kind of shocking, considering how the world's on fire. So it's really kind of a fascinating area. Again, this kind of underscores it, that suicide rate is in the lowest middle income. So this is a good one from the CDC. So for hospitalizations for suicide attempts, there's 8 emergency department visits related to suicide. This is for every single death by suicide. 27 self-reported suicide attempts, and 275 people who seriously considered suicide. So again, it's not an inconsequential problem that we have to face. This is a preventable disease. We can address this, and we can mitigate the risk of this. I'm on the scientific review board of the American Foundation of Suicide Prevention. Again, on the website, it's kind of a cool website. It's a lot of resources for patients, but we're going to put in a grant next year because they get pretty large grants. And they actually, all their money comes from doing the suicide walks. They make like $22 million a year on research from that. But it's a really cool site because it really has these little vignettes about how sleep can affect your ability to die by suicide, et cetera. So what about chronic pain, substance use disorder, and suicide? There's a very impressive kind of literature growing up that people with pain, anywhere from 18 to 50%, want to die by suicide. Nicole Tang is a psychologist colleague of mine at the University of Warwick in the UK, and they did this systematic review that said that if you have pain, you were 50% more likely to die by suicide than you don't. That's pretty strong data. What about suicidal ideation, substance use disorder? 40% of patients who seek care are having suicidal ideation. And it's interesting, go to a methadone clinic and you say, I have a history of suicide, and they won't let you into treatment, which I find abysmal, honestly. So you're just going to push them over because they don't want to deal with all that, that the less the better. If you look at people who have an alcohol use disorder, they're 10 times more likely to die by suicide than the general population. If you have an injection use disorder, you're 14% more likely to die by suicide. Is anyone kind of shocked by these results, or does it make sense to you? And we're going to drill down to why are these populations so vulnerable compared to the general population. So this is a study that was done about opioid overdose survivors, and 60 adults receiving inpatient detox and stabilization who reported a history of opioid overdose, completed questions about suicide, etc. And 1 in 5 of these people with a history of opioid overdose reported intention to die. I was trying to get a grant. I have many grants that have failed. I have a grant kind of art graveyard someplace, but I wanted to do a study where you went into the ED after someone overdosed and do kind of both qualitative and quantitative evaluation. But I think the assumption is whether they just are dumb or they took too much fentanyl but it's a high percentage actually say I want to die by suicide. So I'm just going to just do a little bit more. And I think that's been kind of ignored too. So this is a study looking at profile of patients with opioid use disorders presenting a history of suicide. So suicide rates are higher for people with opioid use disorder compared, we talked about that. This looked at the opioid agonist treatment interns who present with a history of suicidal ideation or attempts, according to concurrent comorbid profiles. So what they found was basically the patients who reported chronic pain were 2.59 more likely to report suicidal ideations compared to ones who didn't prevent. So these are all people that get into an inpatient detox. The ones who said they attempted suicide, it was higher among people with chronic pain. This is a study we just came out in 2023. So I had a large R01 grant where we're trying to find the unicorn of the genetic marker of opioid use disorder in pain patients, which we're always chasing. Dr. Kranzer will tell you he's always chasing it. He'll tell you he caught it, but I don't think he did. So what we did, we had patients who all started with no history of substance abuse except nicotine. They developed chronic pain. They were all exposed to opiates, right? One went on to develop an opioid use disorder. The other groups did not. So it's this real great comparison, apples to apples, people, they all have pain. They all got subjected to it. And we're trying to find that genetic marker, but we have a lot of data about sort of the phenotypic marker. So that we took a subset of 609 patients. So that, again, they've been on opioid therapies for 6 months, developed OUD or did not. So cases compared to controls. And we looked at risk of suicidal ideation based on what's called the SBQR. So the total 609 patients, 18% were at high risk for suicide. And of those at high risk, 51% were ones who had pain and opioid use disorder. So my hypothesis has always been that you have one group of patients that are vulnerable and isolated and kind of not validated, and then you add another kind of stigma to them with the addiction. And this just looks at kind of odds ratios. But if you had chronic pain and opioid use, and everyone knows odds ratios, right? It's 3 point. People get published odds ratios on like 1.4. So 3.4 is significant if you had both of those. Same thing with diagnosis of depression, which is very common. Depression and suicidal ideation comes together. Patients with pain have high rates of depression and anxiety, and that was significant. And then we looked at what's called the PSPS. We're going to dive into this. This is a concept of mental defeat that Dr. Tang had kind of developed. And again, and catastrophizing. Catastrophizing is that the patient feels overwhelmed by their pain. They say, why don't you go over for a barbecue? And they start getting shaky, like, I don't know if I can do it. My pain's going to be worse. They're so focused on the pain. Those are both significant, along with the chronic pain and opioid use disorder. So we're going to kind of drill more into this as we go along. What I find fascinating is that we've been obsessed with opioid use disorder. What's the easiest drug you can buy? Alcohol, right? So they've actually stopped screening patients for alcohol abuse. They are so focused on the opiates, but more patients have a problem with alcohol use disorder than opioid use disorder, and also nicotine. So this is a pain interference prospectively predicted the development of OUD. So these are people who can't function, and so I think a lot of times they start with kind of chemical coping, like I'm bored and I'm depressed, and I'm just going to start drinking to kind of numb myself. Particularly people who have PTSD. And this decrease in alcohol consumption is associated with reduction in the rates of acute pain severity. So acute pain frequency, the days with pain, is also associated with the diagnosis of alcohol use disorder. And ones that had chronic pain tend to have higher rates of alcohol use and alcohol use disorder than the general population. So again, and part of it is, does everyone know the difference between misuse, abuse, and addiction?
Isn't like misuse is just like more like occasional use, like sometimes there's like binge drinking, but you're not like using every day. And just like abuse is like you're using for reasons like, like either like numbing pain or something, and then addiction is like.
So it's a misuse is using a substance for what it's intended. So having a beer at the Phillies game, maybe 3. Having a beer at the Phillies game with your dog is used as, you're not. So in the pain world, you're prescribed 2 Percocets a day for pain, but you take 3 for pain. That's misuse. Abuse is using it for what it's not intended. So opiates are interesting because they have a strong anti-anxiety effect, and they actually have like a hedonic effect for depression. So before they had antidepressants in the 1950s, they would use opium for the cure of melancholia. So they'd microdose like the opium because it kind of gave them this high, this buzz. So most patients with pain have sleep disorders. So oftentimes I'm going to take all my medicine at night to go to sleep. That's abuse. It's not what it's intended for, right? Or I want to treat my anxiety. Addiction is out of control use, right? Not craving, not for pain relief, craving for something else, right? Negative consequences. Someone who's drinking a lot and they're missing times at work and they're getting fired. That's more of an addiction. So it's really hard. I see probably 7 patients a week that are referred for an evaluation whether they have an OUD or not. And I always say it's like 1 out of 7. They kind of misdiagnose them because I had one guy who was like 35 and he was getting treatment for leukemia, and he was on high doses of opiates, and no one can figure out why. So one of my anesthesia pain fellows, never did psychiatry or psychology, said, you had to see this guy because I'm sure he's a male borderline and he has an OUD. And I saw him with his lovely wife, and I'm going like, well, it's not a borderline. And I said, why do you think it's a borderline personality disorder? Well, he said if he didn't have pain relief, he couldn't play with his kids. Clearly, he's manipulating. So I said, you know what? I won't pass gas in the OR. Don't play in my field. And it basically was anxiety because he had 2 kids. He was afraid of dying, and the opiates were just like this anti-anxiety kind of effect. And once you got his depression treated, his anxiety treated with like antidepressants and cognitive behavioral therapy, his opioid dosage just went way down. So it's really kind of a tricky thing, like what is really abuse, what is really, misuse and addiction. But again, alcohol is really easy to abuse. We're going to try to put a book together looking at pain and substance use disorders beyond opiates, because that's been the focus for everything. It's also this whole literature on nicotine. And nicotine is another one that is heavily done, and we'll talk about a study about that later. So 1/3 to more than half of individuals seeking treatment for alcohol use disorder report pain. So what's the underlying theme I'm saying? Pain, and emotional pain and psychological pain kind of lap over each other in the brain. So sometimes people can't separate the 2 of those. So this is a study looking at electronic health records of National Health Service that were used to identify individuals who received the diagnosis of alcohol use disorder in Bologna, Italy. And the crude suicide rate per 100,000 was 2.93, which is extremely high, with an AUD, which was significantly higher than the general population. So again, the idea is we should sort of go beyond opiates when we screen people. And again, a lot of patients come in with alcohol use disorders that we just completely ignore, and it's an unfortunate. So what about the risk factors? So there's really 5 risk factors for patients with pain to have a risk of suicide: sleep, pain intensity, pain duration, pain type, and opioid dosing. Anyone here sleep deprived? Or are you just summer? Do you remember the last time you were sleep deprived, studying all night? How did you feel physically and emotionally? Like a dumpster, like a dumpster fire, right? I remember doing all nights in college and just, I would you get really hyper, right? And then all of a sudden you just crash. So these people that have long-term sleep disorders, it really puts them in high risk for anxiety, depression, and death by suicide. So we're going to focus on a few of them. So this is a study that was done in what year? It was 2021. So it was a relationship between pain severity, insomnia, and suicide attempts of patients with chronic pain. So they actually had 4 groups. So no or mild pain plus no insomnia, low pain, no insomnia, no mild pain and insomnia. So low pain and insomnia, moderate to severe pain and no insomnia, and moderate to severe pain plus insomnia. You know the answer to the story, right? What groups would be the highest? So again, they revealed those with both moderate to severe sleep and depression were the highest risk for suicide. And you can see that, right? Pain is higher, sleep is higher. So sleep intensity is another one. So what we've been doing, I don't think I have the study in here, but in the VA, they've been tapering all these veterans off of opiates, whether they engage in aberrant behavior or not. The 9% increase in completed suicide, not ideation, which is really rare. If you look at suicide rates, it's like 0.5%, 2%. And that there's also they transitioned to heroin. And these were not people that had opioid use disorders. So we they rapidly, kind of detoxed them. They had huge withdrawal and they wanted to die by suicide. So again, there are lots of things we can mitigate in this population to avoid death by suicide, like actually manage their pain. So we published an article in 2018 looking at the United States medical licensing exam. We had 20 pain experts sit down on Market Street where they have the USMLE, went through 1,500 random questions that reflects curriculum of medical school. There was less than 3% were on pain competencies. So I asked all my medical students, for ones I teach anesthesia fellows, how many hours did you have in medical school? So they have no background in it. You understand the Krebs cycle, which makes you a good gardener, but not a very good physician. But I mean, there's no knowledge to it. I don't know, at Penn Medicine, Dr. O'Brien, when he was here, first year medical students here got 25 hours in addiction. It's down to like maybe 1 or 2, right? So it's this whole shift that doesn't even make sense to me. I mean, what costs the most money in this country? Mental health problems, substance abuse problems. And so physicians are coming out with no core competencies in either one. And that's really a problem here. So patients, what are you laughing at?
The med students.
Yeah, first year.
How many
curriculum was not good enough.
Right. You're Penn, right?
Mhm.
Oh yeah. It's not, I'm working with one of the medical students. There's a Geisinger came up with like a 1-week really intensive program for first year medical students on a biopsychosocial evaluation treatment planning for pain. So I'm going to try to steal that. And problem with Penn or any other place, breaking into the curriculum is amazing. So how many classes did you take that you thought were really going to make you a good doctor?
I guess those must come later.
Biochemistry? Yeah, biochemistry. That's going to do it. And you do know the Krebs cycle, right? So a lot of these factors we can mitigate if we were just kind of cognizant of it and do something about it. But there's too many pain patients and not enough pain. I'm a pain psychologist and I'm one of 4 in the tri-state area. And I'm manic, but I'm not that manic. So if we look at the number of patients who have chronic pain, which is probably like 60 million in this country, there's like 5,000 board certified pain physicians. And most of them are interventionalists. They want to just, do intervention. So I used to run the orthopedic inpatient pain service, which was really awesome because we take these people with these comorbidities, depression, anxiety, pain, and we admit them into HUP. And it was a medical floor. We had specialty physical therapy, occupational therapy, aquatic therapy, nutrition, behavioral health, pool therapy. And it was really cool because they could really personalize for each patient because you're working them every day. And you have the support of other pain patients. So there are about 1,000 of these in the late 90s. There's 2 left, one at Hopkins and one at Stanford, because they're heavy in personnel and they don't bring in a lot of money. And in a lot of countries, it's the opposite. My friend of mine just moved to Belfast, Ireland, or up in Northern Ireland, and he's developing they gave him whatever he wanted to do. It's a completely different reimbursement system. So we have these complex people. And what you learn in medicine is that you're trained to be linear. You're a linear thinker, right? Symptom, diagnosis, treatment. How much data is lost there? We used to do more of a biopsychosocial approach to things. My wife, who's a professor in the nursing school, developed hypertension, 6 specialists, $18,000 workup, all of which is negative, right? Not one physician or nurse said, can I ask you some questions? Did you gain weight during COVID? What's your diet like? Do you exercise? which are kind of relevant behavioral parts of managing hypertension. We don't even do that anymore. So I think that, as you become the new doctors in the world, just think about and look a little bit more holistically at things. You'll listen to me at one point. So this is looking at pain severity, insomnia, and suicide attempts. To get another one, the national veterans population. So these are, and these veteran studies, Dr. Kranzler's done a lot of this where you have like 500,000 data points. But as a purist, I always think you can make anything statistically significant with 500,000 data points, But they took 221,000 vets that were initiating pain care, and they're put into 4 groups: no pain, mild pain, insomnia. Just the same one? No. Yeah, it's the same one. I've got duplicate, sorry. Opioid dosing. Mark Ilgens, a psychologist at the University of Michigan, has done a lot of work in opiates, substance use disorders, and pain. And they looked at this retrospective data of veterans data, and they're looking for demographic and other clinical features. And this is, again, the risk of suicide. What they found is that the opioid dosing went up, the risk of suicide went up. So what you can interpret that several different ways. So how would you interpret that data? So more opiates, higher risk of deaths by suicide.
But maybe you're in more pain, so you
Right. And maybe you're more brittle because your pain is poorly controlled. They interpret it the other way around, that these people had more mental health problems, and that's why they were taking the opiates. So you can sort of twist 221,000 data points all you want, but I always make the sense that especially in this day and age, nobody prescribes opiates anymore. So if someone's on pretty high dosing, they have pretty severe pain. And as we talked about, the higher the pain intensity, the higher risk of suicide. So everything is kind of twisted a little bit, and you can't take this data and make a causal relationship. You can just say they're on higher doses. Also, they have higher, access, right? If I really want to die and I have a lot more percodoodles, I could have a higher risk. So there's higher risk, probably more vulnerability in these patients. So there's certain pain populations that are higher risk than other ones. This is an interesting study looking at risk of suicide in 3 groups. It's no pain control, low back pain, and fibromyalgia. Does anyone remember what fibromyalgia is? Fibromyalgia is like this total body pain. And unfortunately, there's no metric for it, and it's mostly women. So they're treated like they're hysterical and that this isn't real, because if I can't see it on the MRI, it doesn't exist, right? It's a real disorder. It's called central sensitization, where your brain's on kind of overdrive. It's genetically, derived. And if you take cerebral fluid from a fibromyalgia patient versus one that doesn't have fibromyalgia, they're lower in serotonin and norepinephrine. So their brain chemistry is different. And it's a horrible drop. I mean, your total body pain. And I gave grand rounds in the rheumatology at HUP, and the head said, "Don't talk about fibromyalgia." The F word. I'm going, "Why is that?" I said, "Why is that?" He goes, "Well, we don't treat it here." I said, "But it's defined by the American College of Rheumatology. So they just don't want to deal with it, right?" So it's a really, so they're high risk group and most patients get depressed with pain because no one validates them, honestly. I mean, they come to see me at the pain clinic, "You're a psychologist, they think I'm crazy." I put it in all perspective of science, right? And once you say 2 things to them, "I believe you have pain, I don't care if the MRI says, and I believe you're suffering," just changes everything. So a lot of women with it's mostly women, again, so there's this kind of sexist part of it, and it's also, and my patients who are really young, who have Crohn's disease and ostomies, "You're too young to have pain." And insulting that is, "You're too young to have pain." So there's a lot of not validation of these patients. So this is interesting. So if you look at the suicide rate, or at least thoughts of suicide, controls were pretty low, about 5%. Low back pain was almost 20%. Fibromyalgia was over 40. Look at these odds ratios. So again, people get odds ratios published at 1.4. So suicidal ideation, the odds ratio was 26 in the fibromyalgia patients, and pretty high in the low back patients, 4. Risk of actual suicide was 48 odds ratio. Right? So it's a very difficult pain disorder to treat, and there's all this kind of bias against them that they feel all the time. Another one is complex regional pain syndrome. This is a really painful neuropathic disorder. Patients, sometimes there's 2 types, type 1 and 2. One is from nerve injury, one is not. And it's the sympathetic nervous system is on overdrive. So think of your transformer, and 220 volts come in and 110 comes out, so they don't cook your charger. It's like 220 comes in and 660 comes out. So it's this severe burning pain. Oftentimes, look at the foot here. See the foot? This is the advanced CRPS. You can just compare one versus the other. So there's a lot of edema, color change, temperature changes. We don't have a lot to really alter it. We have spinal cord stimulators and blocks, but again, it's a brain disease. It's kind of layered on the brain. So that's a high population. This is one study that looked at a number of patients who had CRPS, and about almost 50% considered suicide, and almost 15% had attempted suicide. Again, it's the same thing. They are trapped in their pain. Why do people want to die by suicide? What's the number one reason? To escape, right? Escaping a bad social situation, escaping a pain condition you can't control, and all the sort of other issues. So we're going to look at 4 types of mediators: catastrophizing, burdensiveness, social isolation. I really want to dive into mental defeat. So this is a study we did with Lily Brown, who's an assistant professor here, and Kevin Lynch, who's our statistician. So it's the same kind of thing. These are patients, 500 patients who had chronic pain that we followed for a year. And we're looking at pain catastrophizing, again, feeling overwhelmed by the pain as a predictor, and looked at other things like other ways of coping, like praying and, beliefs. And we were kind of looking at suicidal ideation, depression, pain interference. But catastrophizing was the number one thing that predicted suicidal ideation. So this is a nice prospective study. So number one thing was catastrophizing. It wasn't depression, right? It wasn't, using other skills. So catastrophizing is what we target in cognitive behavioral therapy, is to really change that irrational thinking around their pain. This is another study by Kathy Kranzler. What she did was 113 patients were coming into a pain clinic. And they did the typical depression and anxiety scale, but they asked one question: it would be better for everyone involved if I were to die. That was a reflection of burdensiveness, that I'm a burden on my family and burden on my society. Results revealed that perceived burdensiveness was the sole predictor, not depression, not anything else. So I am a burden on myself. We did a study a number of years ago looking at 466 patients that were coming into our behaviorally based pain program. 26% endorsed suicidal ideation. We looked at physical abuse, sexual abuse, history of depression, but socially withdrawn was another one that was really high. So this fits with what's called Joyners' theory of interpersonal theory of suicide. And what it is basically is that the desire of suicide is kind of a combination of the thwarted belongingness, I'm alone, and I'm a burden. So many people have ideation, very few go into actually attempt. What leads to lethality is the person gets numb to all of it. So if a patient comes in and may say, I'm going to kill myself, I'm not that worried about it. The patient comes in and says, I'm fine. I mean, their life is a country western song, but I'm fine. And everything just gets really dull and really muted. That's where they're at higher risk, because it seems like the right thing to do. So most patients with pain, a lot of my patients that I see, they lose their jobs, they lose their family roles, their family goes on without them, right? So there's this whole sense of isolation that they have. Patients with substance use disorders, right? Been through their 4th rehab, and their parents have spent a fortune on them, and they keep relapsing and relapsing. It's a burden on my family. And there's a lot of isolation and substance abuse, right? Kind of by yourself. So these are things that are kind of theoretical kind of construct to think about. And that's also why I think patients with pain and substance use disorders are more likely to have died by suicide, because they have a double dosing of all this. I mean, can you imagine having a chronic pain that can't be controlled, and you have substance use disorder, and what that hell must be like? Mental defeat is really interesting. It kind of comes from social rank theory and cognitive behavioral exposure theory. It's a concept that kind of characterizes a deeper impact on self-concept. So catastrophizing this pain is overwhelming me. Mental defeat is I no longer belong. I'm not who I am again. I don't exist as how I am. It's a state of mind marked by a sense of loss of autonomy, agency, human integrity. It's a type of self-processing where perceived pain results in negative beliefs about themselves, not just the pain. Do you see the sort of difference between those two? Some of the comments that patients say are defeat of the mind. Pain is taking over and you cannot cope with what you're supposed to do. I just felt everything had beaten me and there's nothing I could do. I couldn't fight anymore. The pain belittles you as a person. It's like you're not a human being. And it's so powerful when I see people shifting from catastrophizing to mental defeat, where they just go like, I don't exist anymore, what I used to be. And they're very stuck in the past and the present. They can never look at the future. So the past is, I looked at what I used to be and what I'm not now, and they keep comparing themselves to that. So they feel they've kind of lost themselves to the pain. So Dr. Tang did the study of looking at 62 chronic pain patients. 12% had one suicide attempt, 10% had two or more. They looked at the Beck scale of suicidal ideation, which is developed here at Penn, looked at depression, anxiety, all the ones you would consider to be risk factors. And what they found was that anxiety and mental defeat was the best predictor of it. So what do you do with mental defeat? When someone feels they've lost themselves, what do you do with that? How do you treat that? I can treat pain catastrophizing with cognitive behavioral therapy. How do you treat someone where they feel they've lost themselves? And that's really kind of an interesting thing. So we're going to try to put a grant together for the American Foundation of Suicide Prevention. She's been doing these things about storybooks, because her feeling is, again, that people get stuck in the past. They're always comparing themselves to the past, always comparing yourself. They can never look forward. That's why suicide looks like a good option. So they've been putting good storybooks, like from Lady Gaga, who was sexually abused and had all these problems, but went on to do amazing things in her life. George Clooney, who had a severe back injury and thought of suicide, and how he kind of moved forward in his life. And they have patients kind of journal around that to get them saying that you feel you're in this place, but you have to start looking forward. So we're kind of playing with that intervention. So this is a risk assessment and intervention. So there's a number of assessments we do. When someone comes in, you have to look at their mental health, depression, anxiety, the pain catastrophizing, sleep disturbance, and the suicide risk. And again, OUD screening. So there's lots of different mental health screening tools, the Beck Depression Inventory. I tend to use the second one down, fast screen for medical patients, because most people use the PHQ-9, which maps on the DSM-4 criteria for major depression. But two questions are I think are misleading. One is sleep and energy, or as vegetative signs of depression, but most patients don't sleep because of pain, and that's not necessarily because of depression. The Beck inventory for medical patients takes out all the sort of the physical symptoms of depression and looks at just behavioral and emotional ones. This is a pain catastrophizing by Sullivan. 13 questions. Anything over 19 is considered clinically relevant. I had a patient yesterday who was 53. I was doing a pre-op for spinal cord stimulator. I'm going, there's no way you can do this. Pain catastrophizing is a predictor of poor outcome from surgeries. We have an NIH grant over at Presby looking at people who are undergoing total knee replacements. 50% of those go on to develop chronic post-surgical pain. And the risk factors are opiates, anxiety, sleep, and pain catastrophizing. So we have this canned cognitive behavioral therapy program for pain that we do 1 month ahead of surgery compared to treatment as usual, and see if we can really sort of change that whole dynamic about chronic post-surgical pain. So again, it's a really important factor that, and most surgeons don't take it into account. They just let's do the surgery, and I put the joint in, and the joint's going to be fine. And you show them that statistics, 50% of your patients with a good joint go on to develop these other problems.
Is that because just like they think the pain will still continue even after surgery?
It's part of it, but remember, pain is processed in the brain. So everyone is focused on my arm hurting. It's all processed here. And it's interesting, when you go from no pain to acute to chronic pain, there's actually changes in the prefrontal cortex. So there's structural changes in your brain. So it's not just this descriptive of something. So I think the pain catastrophizing kind of alters the way the brain is kind of percepting it too. And you're right, I think that they perceive that nothing's going to get better. Nothing does get better, right? I'd rather be right than happy. So I think it's a lot of factors. And the whole science of pain, I think, is amazing, because we do everything from the neck down and think we can cut out the pain. I had a woman who's 37, it's on her 5th back surgery, 5th. Fusion, redo. The outcomes for low back fusions are horrible, right? And again, it's that medical mentality. A lot of countries have Western and Eastern clinics. Like if you have a burst appendix, go to the Western clinic. If you have a chronic condition, go to the Eastern clinic. Treat it in a different holistic manner. And so the whole idea is neuroplasticity. That's what happens between acute and chronic pain, and it gets mapped over the whole brain. And that's not going to be altered by giving you an injection in your back. I tell our pain fellows, I said, every intervention you learn for chronic pain has a shelf life of a tuna sandwich. And you're going to come out here as a technician or a physician. But in 1 year, and they're really good docs, but they're anesthesiologists, one of the most linear physicians, and you have 1 year to teach them how to do the rest of it. It's just really hard. So again, catastrophizing is a risk factor for lots of bad outcomes. This is that scale that looked at mental defeat. Again, a very strong predictor of outcomes. Sleep quality, the one's used a lot is the Pittsburgh Sleep Quality Index, which is pretty good. And then there's a Promise, which is out of the NIH, has very short sleep ones. And you don't want to have patient burden where they're filling out 10,000 pages. So, there's good brief plenty. But if if a patient comes into me and they have high in depression, poor sleep, high pain catastrophizing, high mental defeat, that's a recipe for dessert, for bad outcomes. And we have to kind of look at that. But what do you think we'll get to the social part. Here's the ones that are used for opioid abuse and screening. The top three, the ORT, SOAP, and DIRE, that's if you're thinking about putting someone on an opioid, and it gives you the risk stratification of whether if they're going to have aberrant drug-related behaviors. It's not a measure of whether they're going to develop an OUD. So people may overuse it because their pain's poorly controlled and misuse. They can misuse it for lots of different reasons. Calling the clinic all the time for refills of opiates, that's considered an aberrant disorder, but it's not a surrogate for an opioid use disorder. The next three are ones that you kind of stratify aberrant drug-related behaviors if they're already on opiates, right? Looking for trends on it. And the bottom are just for sort of non-generic for alcohol and drug. So this is the ORT risk tool that everyone uses. Developed by Lynn Webster out of Utah, not psychometrically done. What do you think's wrong with this?
Is that it?
What's that?
That's the whole thing.
That's the whole thing. But there's some glaring mistakes on this, and everyone uses this. And I have to let me point out one thing. History of pre-adolescent sexual abuse is only marked for women and not men. How did he get the ratio of men and women in terms of the differences in scoring? So Lynn's a really good guy. He's really good, but he's not a psychometrician. He picked the history of pre-adolescent sexual abuse women only from one study. But when we talk about ACE, it doesn't have to be your gender. You could be locked in the closet and have ACE. So it didn't make sense. And feedback from patients is from female patients where it makes me uncomfortable to address this question. It makes me really uncomfortable. So he had it kind of, he picked the sort of the rating of it and by just stuff out of the literature without really testing it. So what we did is the same kind of group, right? Patients who developed an OUD, ones that didn't. So remember the cases and controls we talked about? So we went back and actually looked at the ORT, but then we took out the pre-adolescent sexual, it didn't make sense. And we took out all of the weighting of it. And so if you look at the outcomes, and this is predicting, so this is the only group where you're actually predicting OUD because we have these two groups, right? So it's not aberrant behaviors, it's like we're comparing ones who did and did not. So that's a way of predicting OUD. So the ORT did okay, it had a 1.6 odds ratio. When we took out the sexual abuse question, it stayed about 1.6. When we took out both the weighting and the sexual abuse questions, it went to over 3. So this is the only tool that actually measures the risk of developing an OUD in the future. Another one we did was smoking. Again, we talked about ignoring nicotine and also ignoring alcohol. Same kind of thing, same kind of group of patients. So you have to get as many publications you can out of one database. Let me tell you right now, but it made sense. And we did this with Karen Lehrman, who's now a chair of, I think, oncology at University of Southern California. Same thing. We're looking at patients who developed OUD and ones that don't, right? And everyone like that. The ones who had pain and OUD, 80% smoked or had one. We asked one question: have you had a cigarette the last 7 days? Right? 80% of the ones with pain and opioid use disorder said yes. 22% of the controls. Then we controlled all other variables that would be predictive of OUD. So we're just looking at whether you smoke or not. And we found that the risk of developing OUD was anywhere from 5 to 15, no matter how you analyzed it. So one question: have you had a cigarette the last 7 days? Why would nicotine be such a high marker of this? What's nicotine do to the brain?
Self-medication.
Well, so again, addiction's the limbic system, right? And so it's sort of synergistic. It's sort of boosting something that's already there. And if you look at most patients, if you go to a methadone clinic and everyone waiting to get methadone, they're all out smoking, right? So it affects the limbic system, dopaminergic system, and so it kind of sets the stage as they now get an opioid on top of it, and they're predisposed where they're going to take off to the races. So 2 questions I would ask patients: have you had a smoke the last 7 days? And maybe kind of looking at the origin family history. I mean, what are the real risk factors for substance use disorder? Family history, I picked my parents poorly, right? ACE, adverse childhood events, right? Deprivation, depression. I mean, they're all ones that are pretty standard. Doesn't matter what the population is. There's a lot of suicide assessment tools. The one that's used the most is a Columbia Suicide Severity Rating Scale out of Columbia. The P4 Suicidal. The Beck scale for suicidal ideation is kind of interesting. And there's also one about intentionality, like how much do you really intend to do this? But the Columbia is probably the most used, and particularly in research. So once you get all this data, you need to risk stratify, right? Plans, do they have plans? Vague versus specific. Means, no, versus I have a bunch of opiates and I have a bunch. Actually, one drug you can overdose on really well is amitriptyline, tricyclic antidepressants, which are around everywhere. Do they have guns in the house? They have a history of suicide attempts. The best predictor of future behavior is past behavior, right? Level of support. You know, again, asking people about their support is really important. We don't ask anymore. If you have good support system, I think it mitigates some of the risk versus not. Coping abilities, do they have the ability to cope with stressful situations or not? The relationship with the healthcare provider is really important. You know, if they trust you. We wrote a book called Facilitating Treatment Adherence in Pain Medicine. 4 copies were sold. You know, when I get my relative check of $18, my wife goes, wow, married money. But we had these different authors talk about how do you get people to exercise, to change their nutrition, take their medication. Independently, everyone said the same thing, is having a good therapeutic relationship with your healthcare provider. Unfortunately, in today's medical care, it's 6 minutes, and 5 of that is putting stuff into the medical record. So we wonder why people don't follow through. So when you have a good relationship with a patient, they'll be honest with you and say, I'm really tanking here. I'm really going down the rabbit hole and I need help, versus not having it. And then the willingness to contract. So we do all kind of contracting with patients. Now they could lie, obviously, about, you know, here's your crisis center, here's the number for the National Suicide Prevention Lifeline, which is 988. You know, do you have someone, if you really are serious, that you feel comfortable reaching out to? So again, if patient says, I'm not going to contract, and you start just ticking down the list, you can see, you know, how much of a risk they are for actually death by suicide. So the acute phase, what do? Inpatient treatment if necessary, depending on the severity. Pharmacotherapy targeting the sleep, the depression, but not ignoring the pain. That's really important. Don't ignore the pain. If you're going to give opiates, small amounts, have someone else hold it until you get stabilized. And then frequent urine drug testing to make sure they're not putting other substances in their body. And obviously chronic depression. There are people who are just chronic suiciders. I had a woman who was like, she was 60 and lost her husband, and she was horribly depressed, but she was had very strong religious convictions. So she would never, you know, die by suicide because it against her beliefs. But she would get admitted all the time when her potassium would drop out because she was becoming anorectic. So it was kind of a chronic way of just, I'm going to end my life sooner than it should be. One day the potassium will drop out and she won't make it. But it wasn't intentionality, or people will engage in risky behavior. And that's kind of that chronic suicider. And you need regular mental health screening, frequent urine drug tests. You need to really stay on top of it. So let's look at non-pharmacologic and pharmacologic. So non-pharmacologic, we have really 4 areas: cognitive behavioral therapy, acceptance commitment therapy, exercise, and social support. This is what kind of constitutes a biopsychosocial kind of approach to pain medicine. So cognitive therapy is basically pain patients do 2 things. One is maladaptive thinking, which is catastrophizing. The pain has more weight on their life than it should. And kinesiophobia, which is fear of movement. So if you don't move, what happens with your pain? It's worse, right? You get deconditioned, you know, you're not moving. And the more pain you have, the more catastrophizing you have. So the target of cognitive behavioral therapy is to really kind of attack those underlying irrational narratives that become loops in their head. So it boils down to 4 steps: stop, breathe, reflect, and choose. When you're really distressed, stop thinking, stop saying in your head. Do some deep breathing to kind of calm yourself. Reflect. What's the situation? What are my emotions? What am I saying to myself? What are my narratives? Because when people are distressed, their narratives are more negative and irrational. Do you remember the last time you were stressed and you think you couldn't get done? What's going through your head sometimes? You know, like, I can't believe it. So it's kind of having people look at a situation from another perspective than theirs. And it includes relaxation therapy, stress management, cognitive restructuring, skill consolidation, rehearsal, and relapse training. across all pain disorders, it's probably one of the most effective ones, or function and mood. Nothing to do with pain, because that's the hallmark of what a good outcome is. So you're attacking this underlying irrational beliefs that drive the depression, that drive the anxiety. Cognitive behavioral therapy for insomnia is as effective as medicine. It's getting people to change their environment, right? There's stimulus control. The bedroom should just be for intimacy and sleep. People have exercise equipment. There are, computers in there, and it becomes, remember Pavlovian conditioning? The room gets conditioned to do something, everything but sleep. And again, I have patients have like piles of clothes everywhere, and you walk in the room and get anxious. So you get them to kind of have that sleep environment. It's things like, certain foods late at night will help you sleep, like carbohydrates more, and proteins will make it worse, or sugars will make it worse. There's a whole program to it, learning how to relax at night. Best sleeping time is 65 to 67 degrees. So it's a pretty straightforward kind of approach using meditation. Is that anyone woken up in the middle of the night and you can't go back to sleep? What goes through your mind at that moment? Everything goes through your mind. I mean, I call them like the sort of the night demons. All of a sudden going like, oh, no, crud, I forgot to do that yesterday. I got this to do tomorrow. So we tell them, get out of their bedroom, because that frustration will be associated with the room. So it's very, very effective. Getting people to change behavior is a little bit harder though, right? Getting them to change, get the TV out of the room, make it conducive for you. I have patients do one thing. If they can only do one thing, an hour before bedtime, turn down all stimuli. Don't watch the news. I watch this movie. You're watching a movie, Promising Young Woman. It's not a good ending for this woman. That's all I tell you. But I watch it right before bed, and I couldn't go to sleep, because don't watch things that are exciting. If I get them to do just that, wake sleep cycles when they're not. It's like being on college, when you're on vacation and you sleep until 12 or 1. None of you do that. I know that. All you're up for studying. I know you're Penn students. But their wake sleep cycles all over the place. And so again, what we call sleep restriction, start moving back their wake sleep cycle. When you exercise is important, but it's very effective. And so we can do it without a lot of medications.
I have a question.
Yeah.
I'm wondering how nightmares come into this insomnia / pain thing, because for somebody who has nightmares a lot and multiple ones in one night, it's really hard to sleep and really hard to go through your day without thinking of them. Does that ever be?
Yeah, well, usually 1 out of 7 patients that present to a pain clinic have undiagnosed PTSD. So I think a lot of people have sort of maybe less intense PTSD, and they usually have a lot more nightmares with that. That's what I would always do, is screen for post-traumatic stress disorder. People have been in horrible car accidents, or my one young patient who's 35 now, she's had horrible Crohn's since she's 12 and has been in and out of the hospital. And she has this kind of PTSD about hospitals, right? And that always interferes with the sleep. So you have to kind of see what the origin of the nightmares are. I don't do dream analysis. I'm not that smart. So, but I always screen for PTSD because I think it's much more prevalent. I'd say in my Wednesday clinic, which is kind of a mix of different people, I would say out of 15 patients I see, at least 2 will have it. It's not, and usually it's people who have poor, insurance, another bane in our existence. And there are a couple of PTSD centers that will take Medicaid and stuff like that, but oftentimes they just can't get the treatment. And what happens is that it's 40% of veterans that come back from Afghanistan with PTSD develop whole body pain, 40%. So there's a connection in the brain that's going on, and you think about how memories are. Think about closing your eyes and something that was really painful to you, like 5 years ago, emotionally painful. If you think about it, it's almost like you're there again, right? That same sadness, that same kind of visceral response. So I always screen for PTSD in patients where I know they've had history of traumas. So acceptance commitment therapy, I think, is the way to go. I love acceptance commitment therapy. And the first thing the patient says is, what? You want me to accept this? My life is going to be like that? It's not what it's about. It is a mindfulness-based approach. Right? And it has to do with accepting your emotions for what they are. It's a beautiful day. I want to go garden and I can't because of my pain. I'm really angry, right? So as humans, what do? We shove down negative emotions. We shove down negative thoughts. And what happens? It always comes back and bites you. And I love the authors of this because they say that all the psychiatric nomenclature, major depressive disorder, generalized anxiety disorder, are all arbitrary, that your emotions are human and it doesn't matter what it is. It's about psychological flexibility. It's dancing with life rather than wrestling with life, right? So that the components is being mindful of your emotions, accepting your emotions for what they are, allow for diffusion, the emotions to kind of calm down, and then making committed action based on your values. So it's a lot of metaphors with ACT. So I'll say, imagine a chessboard and there's white and black, up here, pieces up here. Those pieces represent your thoughts and emotions. That does not define you. You are the chessboard, and your chessboard is defined by values. So I have a young radiation oncologist from the VA who has like perirectal pain and it won't go away. And he's a Penn medical student. He goes, I'm a good doctor. I got to figure this out. I'm going like, well, sorry, Sparky, you're going to have pain a long time. But he would never make accommodations. His view was I have to push through things, like hitting that brick wall. And it finally just snapped to him. Like I said, what do you value? I value being a physician. I value my partnerships. I value my family. Okay. Those are going to drive your decision making in your life. The rest of it's irrelevant. And he was not spending time with his partner's family. He was not spending time traveling, things like that. All of a sudden, the psychological flexibility kicked into him. He goes, I get it. I have enough money that I can go first class on a plane and I could stop somewhere in between so I can get out and walk around. I get it. I can bring a cushion to sit on when I go to the restaurant. I don't care what people think. That seems like not a lot, but it just turned his whole depression, everything around. It's finding ways around life's difficulties. But again, as you're going through life, we think life is linear, right? You graduate high school, doing a PhD and family, blah, blah, blah. Life ain't linear. Life is twists and turns. So what I do is I have them do a values assessment. And the usually top 3 ones are, usually career, their family or something. I said, okay, that's your GPS. So that defines your direction in life, east, west, north, south. So imagine your direction in life based on your values is west. So you get in your car and you drive to Harrisburg and you said, it's nice. It's not west enough. And you keep driving until you hit Seattle. You want to keep going west on your values. But I have a problem. I'm in a car and there's water there. I got to find another way to keep going west. So there's a lot of metaphor work and people really get it. I mean, when they get ACT, there's been 5 randomized controlled trials that show just with a brief ACT intervention in pain patients. These are all patients with musculoskeletal pain. 3 years later, they reevaluated them. 68% have maintained all their gains. You tell me a pill or procedure that gives you 3 years of durability because you're changing the way they're viewing the world. I'm going to have this pain. So I always tell the example, I have a woman who loves gardening and she loves being creative, wanted to garden, couldn't garden because she had a pain, but was angry and upset and she could follow the kind of ACT way. She goes, you know what? I can go do some other crafts that I can do that really bring me enjoyment. And so it's a whole different way of thinking about life and thinking about your pain. And the pain is just another kind of obstacle to move around. If I can't do this, I can do that. Does that kind of make sense to people? And it's just been amazing. And I like deep pathologizing our emotions because we have all these labels on people. And you have pain, your life's a country western song, and you're not angry, you're not upset about things. It's okay. It's not pathological. Let's not label it. That also is very therapeutic for patients. Like you're right. I have a right to feel sad. I have a right to feel angry. They aren't pathologies. They make the connections really fast. So if you look at cognitive behavioral therapy and ACT for pain and substance use disorders, it's again, a really evolving kind of literature on how efficacious it is for both pain and substance use disorders. And there's a lot of different studies looking at feasibility, acceptability of these, studies looking at strategies to improve pain and enjoy life. So there's a lot of different ones that are coming out. Mindfulness-oriented recovery, enhancement in chronic pain and opioid use disorders, mindfulness-oriented things. So this is the new wave in terms of pain psychology of really helping people to ACT. And I like people to combine the cognitive behavioral therapy and the ACT. So cognitive behavioral therapy is very formalistic, like you stop, breathe, reflect, and choose. So, when I'm being irrational, there's another way of looking at it. I said, but so cognitively you're better, but you still feel kind of angry or upset. That's when ACT comes in, right? That's when ACT comes in. You've taken care of it cognitively. Now you're going to take care of it emotionally. Exercise is another important thing. So anyone here a runner? Let's go for a run. Anyone here exercise? Walk fast, right? I live 3.5 miles away and I always power walk in. So when you do a really good exercise, whatever it is, what does it do to you physically and emotionally?
You feel good,
Right.
productive.
I was giving a lecture to a group of primary care residents, and we weren't talking about anything. And this woman, like, and when someone does this, you know, they're a runner. They're a little wiry, you know. I know this is off the subject, but how do you get people to stop smoking? I said, "Are you a runner?" She goes, "Yeah." "How'd you know that?" I said, "Why do you run?" She goes, "Because it makes me feel happy." I go, "You don't do it for cardiovascular conditioning, weight control. You do it because it makes you happy. It makes you less stressed." I said, "You have to figure out what not smoking does for your patient. It doesn't matter what our goals are. It matters what the patient's goals are. So what does not smoking do for you?" Just like running. I think she kind of got it at that moment. But we know about exercise. It releases endogenous endorphins, you know, which is, you know, our natural opiates, right? Can reduce mortality and morbidity, you know. Aerobic exercise has been found to be really strong anti-anxiety agent, right? If you ever get really upset, you're just really upset about it, you just take a really hard walk on campus and you just kind of feel better, right? And we also know that it has a lot to do with opioid sparing. You know, a lot of people use opiates for anxiety. So it's really been very effective, you know, to help people. There was a study done years ago looking at people who are acutely depressed, and they're randomized to 3 groups: the antidepressant of the day, antidepressant plus exercise, or just exercise. The ones in the acute phase that did exercise and the antidepressant did much better. Long term, the ones that exercise had the most best outcomes. So again, it gives you this kind of hedonic effect, and it's kind of up, and your anxiety is better. So again, getting people to embrace that is really important. This is Kathy Carroll, who's was a wonderful research. I think she's at Yale, just passed away, but she has this thing called CBT for CBT. It's all computerized. And they took this group of people that had all kinds of different substance use disorders: alcohol, cocaine, opiates. And they completed this online. And what they found was that 77% of those accessed the program at least once. 77% complete all 7 modules. Satisfaction of the program was high, but participants reported a greater than 90% days abstinence of all drugs. So does it have to be coming into Philadelphia to see me, or can we do some of this more, you know, computerized? I think there's pros and cons of that. I mean, now we have AI we're dealing with. I think the therapeutic relationship is also very important, that you don't get out of a computer. All of this HOPE study we're doing, it's like 640 patients on end-stage renal disease, and we're treating their pain. It's all done with coaches and virtually, but they actually have a relationship with them. And I think that some of this stuff is good, and some of it just takes away kind of what's the meat of therapy is. So this is another study we're in preparation for submitting. We looked at comorbid opioid use disorder, depression, and risk of suicide, our typical cohort. This is a cross-sectional study of 609 patients with chronic non-cancer pain with long-term opioid therapy. Again, OUD, no OUD, you get the point. We looked at all these different factors: demographics, pain severity. And what we found is that depression, you know, obviously was a direct relationship to risk of suicide, but it was kind of mediated by the DSSI, which is a measure of support, social support. So social support was a mitigating factor in these people actually developing suicidal ideation. We'll skip that. So pharmacotherapeutics, any questions at this point? It's too much? Not enough? Just right?
I have a general question. What's like your stance on cannabis use for pain medication?
I think it's mixed. I mean, the state of Pennsylvania, you have to have medical certification, but it includes if you breathe. I mean, they have it on there for crazy things like post-traumatic stresses, or there's no data post-traumatic stresses. They have it on there for autism, and they just want to legalize pot. That's what they want to do. We use a lot of it in the pain center, where we used to, not as much, but I think you're almost doing the opioid epidemic again. So 10% of, well, let me ask you a different question. So how many people with chronic pain do you think develop a true opioid use disorder when exposed to opiate? What percentage do you think? How many say 10% or less? 20%, 30%? Do I hear 40? How many people don't care? So you think it's pretty high, right? It's 10%. Because that's the population. 10% have alcohol use disorders, 10% have, it's no different than any other use disorder. So what we're doing now is certifying everyone for cannabis. And the thought behind it is, well, at least they can't overdose for it. But there's emerging literature that they actually go on to more dangerous drugs. So Mrs. Jones, who's never smoked a joint and never had a substance use disorder, comes in and you expose it to her. sets off her limbic system, dopaminergic system, and it just goes on from there. So it's the same kind of naivety. And part of the problem with medicine is that the patient expects, I paid $40, I'm walking out with something. I don't want your sage advice about how I should exercise, right? And you're trained in medical to do something. We had a crisis with antibiotics because we prescribed to everybody for the wrong reason, right? Now we have these things that are resistant. So I think cannabis has its goals. I'm working with Steve Ross on using CBD for pain. And I think that there's pure CBD is actually very effective. I have a friend who's been a neurologist, does about 30 years. I think he's pretty convincing about pain, but the rest of them are just kind of crapshoots, really, honestly. So I think it has its usefulness in certain patients, like anything else. But if you're going to treat patients with just medicines, you're not going to help these people long term. Fellow up in Boston, blocking his name, Herb Benson was a cardiologist that felt that he could get people to do a relaxation response so they can treat their hypertension and come off medications. Now this is 1960 at Harvard, a bunch of white old dudes with bow ties on, and they thought he was a heretic. They thought, like, crazy, man, we got beta blockers that's better when you feel impotent and you can't get out of bed, but that's okay. But he got a subgroup of people off by learning them to just relax. So he developed this Mind Body Institute that treats insomnia, pain, and women's studies. And what interesting, he gives a talk about the three-legged stool. And that's our healthcare system. So one leg is pharmaceuticals, one leg is surgeries, and the third leg is what people can do for themselves. And he kind of proposes that we kind of let that leg just kind of wither, right? So everything's pills, everything's procedures. So I think cannabis has a law. I think all of these have some efficacy. It's getting the right combination for the patient, which is really challenging. Did I answer your question at all?
Yeah, you did.
But there is strong evidence for pain, but not. So I had one who was 85 and they went to the dispensary and she got so high on THC, which is good. She kept rolling out of bed. I said, "What's that bruise on your arm?" She goes, "I keep falling out of bed. I didn't want to go to bed." Okay, well, you shouldn't be using that much. So we're going to focus on pain and substance use disorders. So we have 4 options, right, for medications for opioid use disorder. We have methadone, buprenorphine, extended release oral naltrexone, and ketamine. We're talking about ketamine too. So these are the 2 we're really going to focus on. And again, this is pain and substance use disorder and suicide, right? That's the group we're looking at. So buprenorphine is a really interesting drug. It's an anesthetic in 1985 in London. And it's really interesting because it's a partial agonist. So the mu opioid receptor gives you the analgesia, but it also hits a kappa receptor, which kind of caps the euphoria so that you have much lower rate of respiratory depression. So they found that it was really helpful to use this for people who had heroin addictions, right? And they could dose it and they would get, they wouldn't have the craving for heroin. So this is an interesting one. These are 51 patients who had met criteria for OUD and major depressive disorder. They went to 3 groups. One was received single sublingual buprenorphine, 32, 64, 96. They did a 3-day trial, right? And the outcomes were pretty amazing. Significant reduction in suicidal ideation. Just knocked it out like that. And I think it's at the kappa receptor that occurs. There's no difference in the dosing on it. So just a micro dosing of buprenorphine stopped suicidal ideation. And I think that's pretty fascinating. And it was kind of the interaction between the mu and the kappa. So these are people that have opioid use disorder, severe depression, and suicide. So it was really pretty effective. This is what it looked like. This is the Beck scale of suicidal ideation. Again, what's their intent of suicide? And no matter what the dosing is, all their ideation just dropped off. I think that's kind of cool. And remember that buprenorphine has a pain reliever. So if I have someone comes in with substance use disorder, no matter what it is, pain, and they're high risk for suicide, you can microdose the sublingual buprenorphine and actually get this really good response. There is only 2 on the market that are just for pain. One's a patch they can wear for 7 days, and one's like a buccal thing. It's like gum that you pop into your mouth. So I think this is a really interesting drug that we can use with patients to keep them out of harm's way, keep them from relapsing, maybe control their pain, and also kind of reduce the risk of suicide. This is another one looking at a randomized control trial. This is using placebo control. These were severely suicidal patients that they didn't have substance abuse or pain. They just came in saying, my intent is really high to die by suicide. And again, they randomized it and they gave them a microdosing of buprenorphine or a placebo. And again, what they found was a significant difference, right? The green is a placebo group. This is all their ideation. Just significantly went down with the buprenorphine group. Suicide probability, again, significantly went down with buprenorphine, not affected in a placebo. And then sort of the mental pain also helped. So I think it's a really interesting, I was doing this talk at something called prescription drug and illicit drugs in Atlanta, and the psychiatrist kind of like brought this up, and she goes, remember, this is a dangerous drug. And I'm going like, yeah, so is killing yourself, like, So this is now we're looking at the systematic review of ketamine. So ketamine is an odd drug. We use it like interoperatively a lot in the hospital. It's not an opiate. It's a kind of a different type of medication. A lot of infusions we use it. So it's a colleague of mine who was one of our former fellows uses it exclusively. They've been using it for PTSD, for severe neuropathic pain, and it's been pretty effective. So this was a study looking at just kind of randomized controlled trials. 10 and 11 had comparison studies, so they had placebo effect. Primary outcome was suicide items from the clinician's perspective, how the clinician felt they were, from the patient's perspective, and self-report. What they found was in the green is the ketamine and orange is a control, that significant clinical administration of suicidal ideation and patient. This is with one infusion of the ketamine. We have nasal ketamine, which is actually for refractory depression. Psychiatrists use. We have to be in the office, but it's a tricky drug. I mean, people hallucinate on it. People don't do well on it. So this needs a lot more research. But I see that someone comes in who has pain, substance use disorder, and high risk for suicide. These are the pharmacologic choices I think has a better outcome for all three. This is another study looking at a prospective double-blind superiority randomized control trial, 156 patients randomized into placebo or ketamine, 2 40-minute interventions and infusions of ketamine. And again, more participants receiving ketamine reached full remission of suicidal IDs at day 3. And again, you see the same kind of trend. They're drugs that need a lot more research on because they're not benign drugs, but I think it has real potential. I mean, just giving people just a drug du jour to treat their pain or their substance use disorder is not going to help them. You have to have novel ways of doing this. So my last line is that suicidal ideation is highly prevalent in patients with pain and patients with substance use disorder. If you have both, it's a double dose of all the factors we talked about, psychosocial factors, medical factors, and making them incredibly vulnerable for suicide. Some of the mediators are the burdensiveness, mental defeat, social isolation, poor stress coping skills, and catastrophizing. Almost all of those can be mitigated, right? What do you think the downside of this is? If I say I have the perfect program, you come to me and I have the perfect program for you, we're going to mitigate all these. What's the reality there? Access, right? Yeah. I mean, in Penn Med psychiatry, to see a social worker is a 9-month waiting list. See a social worker. See a psychiatrist, it's easier to see the Pope. So I think we have to be more creative in a way of how we deliver some of these services. I do believe telemedicine has a role in it. I think it's oversold because I think the therapeutic relationship is very important here. We've got to find other ways of delivering this than what we've been doing. Again, risk factors, sleep disturbance, pain intensity, pain coping, social support. I had a patient who had a severe neck injury. He was a track coach, and he also taught computer science at a high school. And he really loved what he did, but couldn't work anymore. Highly suicidal. And he was on all kinds of antidepressants, but he would sit at home. And I saw him for a while. And we kind of had a rapport. And I said, here's the thing. I'm not going to treat you anymore unless you get your butt off the couch and go someplace. So he's like, no. I said, you're a teacher, right? You like teaching. I want you to do one thing. Take on one adult literacy case. Just one. No, I'll do it. It's like, I'm good at twisting arms. He came back less depressed. He goes, yeah, I meet this guy every week, and he's looking forward to meeting me, and I have something to do. I said, so that's not good enough. We're going to take on 2 more. I'm very aggressive, I do. And he took on 2 more. And I said, you love, cross country and coaching, but you don't have to run it, but you're still certified to be an official. So why don't you just add that? You can sit in a chair and still be an official. Added that. Depression got better and better and better. So that lack of purpose and being isolated, I mean, these are things we can help people so they don't die by suicide. What's even worse is you just have this psychological, horrible pain all the time, and you just feel like you have no worth anymore. We need global access to mental health. That's a problem. I was giving a talk in Dublin a year ago, and I met this psychologist from the UK, and I was talking about the National health service. I said, well, I guess they don't let you have a lot, time with patients. She said, if I want 100 sessions, they give me 100 sessions. And she goes, the access is not as bad as people think it is. I just think we have to stratify who needs the treatment, who doesn't. That's the problem. It's just everyone can come in. But this is a global problem. 700,000 people die every year. Every 40 seconds, someone in this world dies. So we're doing something wrong here. And some of it is political, right? Poverty, there's ACE issues, access to health care. And again, these are things that we can't do in a lab or in a clinic. I mean, it's a bigger issue, but we can do our part. So the future is we need to have more delivery systems that are efficacious, that we can get to more people. We need to look at the phenotype and genotype. There is some genetic possible, predispositions to suicide, mostly around serotonin. So again, we've looked at it, but I think we can do a little bit better. It is really hard to predict who's going to die by suicide, honestly. It is really hard. When you look at the potential efficacies of the buprenorphine and ketamine, I think it's a really powerful drug, but I don't think we've fine-tuned it enough. Like, what really is the dosing that's safe enough for these people? How long does that really last? When the trial's like 3 days, that's not good enough. And so we need a lot more data on this. So I want to share with this. This kind of brings my point home. About 10 years ago, I got this email from a woman from Portland because she had read an article I wrote on pain and suicide. My 45-year-old daughter suffered for 4.5 years of constant back pain, unrelieved by narcotics and mostly ignored by all the MDs I took her to. On January 9th, 2012, she killed herself by jumping off a high bridge to end her agony. It was her relentless, agonizing pain which eventually killed her. When she recognized that the only narcotic she could tolerate no longer worked, there was no hope left. She knew her old age would be a nightmare. It was then she made a decision to get out of her inferno. This just really struck me really hard, And she sent me some beautiful pictures of her, I don't know, that's an internet relationship. That says it all, right? These people feel isolated. They feel like no one's really helping them. They're not validated. And when you have pain and substance use disorder, people just, it's a deadly duo for people. And again, so I try to disseminate a lot of this to a lot of people. So just people be more aware of it. Just be more aware when people come in. One of our fellows, pain fellows, I said, this is really important about suicide. He goes, I don't know how to deal with it. How's that? I won't ask him about it. I said, that's not a really good idea, but then I talked about litigation. He changed his mind, but we can't ignore this. We can't ignore this, but we do. Two things a primary care doctor never wants to ask on a Friday afternoon: what's your pain level, and are you suicidal? Right? Because we don't know what to do with it. So I think that if you're interested in this, the American Foundation of Suicide Prevention is a really cool not-for-profit. There's lots of things for patients and for families, and some research ideas. I think the resources are there. I just think that suicide is like all of our other social ails we have, right? It's about it. We know everyone knows what the solutions are, right? But it's about moving the needle forward that's hard. But even save one person, save 2 people, then you can go to bed at night. Any other questions?
I have 2 questions. So the first one was
You can have 3.
so the first one was ketamine. Do you think it would be, I guess, like more efficacious if it was like ketamine assisted therapy rather than just like intravenous ketamine?
Yeah, so the intravenous is usually used for the really severe complex regional pain syndrome ones. I think it's overkill for PTSD. I mean, they average some of these things. I was on a trip to the Galapagos Island, and this guy was an emergency medicine physician. He never practiced emergency medicine. In Atlanta, he just had all these ketamine clinics everywhere, and I don't think that's good care. Like, who are you giving it to? So I think it needs a lot more work. The infusions are really heavy. I mean, they are really heavy. I mean, they have to have a nurse sit there with you. I mean, you literally start to dissociate. And for PTSD patients, they probably like that, right? The microdosing, I think we haven't done enough work about. The nasal spray is kind of interesting because that's for refractory depression. So it doesn't do much for pain. So why not? So I think it's a lot more parameters we have to kind of discover, like what really is efficacious dosing. Again, these are all impressive, but they're 3 days, 2 weeks. A lot of the drug trials are 12 weeks long. That's it, and they show a response to placebo, but it's 12 weeks. That's not durability. That answer your question?
Yeah. And then I guess the other one's like, has there been any studies, or do you think like even like psychedelics could like play a role in like treating pain and
Absolutely. I mean, there's a bunch of new NIH grants coming out for psychedelics. And Steve Ross, just look up his stuff. He and some colleagues did one with psilocybin for acute alcohol use disorder, and was really effective in treating it. I think in the time when, you know, just say no to drugs, there was really interesting research in the 70s on LSD. I mean, therapeutically, and everyone said, oh, they're all drug heads, you know, we have to stop all this, and so they just stopped all research on this. It's only now that they're starting to come back to it, because most of the stuff we have, you look at most antidepressants, only 35% of people respond to it. Only 35%. Most of the drugs we have for neuropathically mediated pain, or nerve pain, we have like 3 drugs, 30% respond to it. There's a big gap there why people don't respond. Maybe there's the wrong molecule. Maybe we have to have something else. But the patients who have pain and substance use disorder, I think it's just even more challenging, because it takes all the problems they have and just doubles it. You know how people with substance use disorders are treated. They're treated like garbage. You know, my wife did a study, looked at all the AMA discharges, you know, against medical advice. And these were all people who came in with OUD. They had sepsis from the injections and stuff like that. And a huge number just kept leaving, you know, against medical advice because their pain wasn't treated. One woman was admitted 13 different times in a year, cost the system $700,000. You know, because they don't have insurance, so it's all this heavy medical care that you're not getting reimbursed for, and it was only because their pain wasn't treated. So again, there's pain is a, and she does some interesting stuff about someone comes in with severe opioid use disorder. I mean, they're using heavy fentanyl and now we're using xylazine. You've seen that one yet? The horse tranquilizer. Great. You know, your whole arm can become narcotic with xylazine. I was talking to the psychiatrist in Dublin, so I'm taking a sabbatical into Ireland and England, and she goes, we just have heroin here. I said, we're so much more advanced than you. We have horse tranquilizers. Heroin's passe, you know. So yeah, so it's a tough area, but I think it needs more, you know, attention that it's gotten. I mean, a lot of the funding in the NIH, like the HEAL grants, is all about how can we reduce opiates. That's our goal, and they threw hundreds of millions of dollars. Well, therapeutically, no one prescribes opiates anymore, you know, so they're still spending money on this stuff, where maybe we should sort of shift that money into other areas that can be helpful. And I think suicides have hard people to work with, you know, it's a high, you know, kind of liability, you know, treating these people because they're very brittle, but ignoring it is not a good answer either. Any other questions?
In a community like Philadelphia, if I know you said that there's very few providers or physicians that work in pain management and substance use treatment, but in a community like Philadelphia, say, you know, people who have substance use but don't have insurance, and they probably don't seek treatment because of these factors. Like, are you aware of any initiatives?
Oh, there's what's it called? Was that prevention point? Yeah, that's and they're fighting that one too. Maybe you can tell her what prevention. Are you familiar with prevention?
Like a safe, like people go and they get like needles and like it's like a prevention method, basically.